Okay guys, so now I'm going to be discussing the main components of the respiratory system, both upper and lower. And I know I drew them a little bit backwards, but it gets your brain to think a little bit more. So let's go ahead and begin. Let's first identify the major anatomical structures. When we talk about the upper respiratory system, we have to discuss the nose, the nares, the throat, which we know it as the pharynx. Okay, not pharynx, but pharynx. And the pharynx is broken down into three segments: the nasopharynx, the oropharynx, and then the laryngopharynx. And this is just talking about the major anatomical structures when it comes to the throat, right? Pharynx means throat. And so the nasopharynx is behind the anatomical location behind the nose area. The oropharynx is behind the throat of the oral area. And then the laryngopharynx is a little bit lower, down here, where you have the opening of the airway, where we talk about the opening of the airway is the trachea. But that opening, we have a lot of structures there that we call the voice box, the larynx. And that's what allows me to project the sounds that you guys are hearing right now because of the vocal cords. Okay, we have muscles there as well. So it's important that we understand that those are the areas of the throat: nasopharynx, oropharynx, laryngopharynx. And on top of the larynx, you have something called the epiglottis. And the epiglottis is a smooth muscle that closes off, and it closes and it protects the airway every time that you swallow. Deglutition. Every time you swallow, it closes off and it protects the airway, and that's what prevents us from aspirating every time we consume food. So just keep in mind that you have those two different structures. You have the opening of the airway, and in the back, posterior to the trachea, you have the esophagus, which is where the food propels down to the stomach. When it comes to the respiratory system, you have to understand some basic concepts. The airway inside the nasopharynx and the entire pharynx and just everywhere inside the respiratory system is covered with mucous membranes. And the mucous membranes is responsible for trapping any debris, any particles, and you have microvilli and cilia that mobilize those particles up towards the exit of the airway, and then it triggers the cough, the sneeze reflex. And that's why sometimes you feel like sneezing, because those particles are being moved upwards towards the lining of the mucous membrane, towards the area where you have other nerves that trigger the cough and the sneeze reflex, so we can remove all those foreign particles so we don't develop any infection. Another main purpose of the nasal cavity is to warm up and humidify the air. It's really important because if you guys have ever taken a jog, especially like at nighttime during the winter, eventually that cold air, you can't warm it up anymore because it's consistently cold, and it ends up hurting your sinuses. That's because it constricts the blood vessels, and cold causes pain sometimes when it's sufficient enough. And so the whole purpose of your nasal cavity is to warm up that air and to humidify it. Those are very important concepts. You must humidify the air, otherwise your nares become too dry and you may develop epistaxis or nosebleeds. So this is part of the upper respiratory tract. The trachea is the pipe that allows your air to be transported down to the lower respiratory tract, which we'll discuss in just a bit. When it comes to your upper respiratory system, guys, there's a couple of disorders that I want to emphasize, okay? Usually they deal with viral or bacterial infections of the upper respiratory system. I want you guys to bundle up, whether it's sinusitis, whether it's tonsillitis, whether it's pharyngitis, or whether it's laryngitis. All of these inflammation, all these itis conditions are occurring in the upper respiratory tract. The physical elements that are going to be happening is that you're going to have some type of obstruction of the airway, whether it's caused by inflammation and secretions, or whether it's some type of spasms that develop because of laryngitis, let's say, but it's the upper airways. So you want to start thinking of what type of breath sounds, what type of adventitious breath sounds are we going to be hearing. So when it's in the upper respiratory tract, understand that you really want to focus on stridor. Stridor is it's what's happening when your upper airway is partially obstructed. And this signifies occlusion of the airway, which is a red flag, and it necessitates immediate intervention, immediate attention, because we want to alleviate, we want to promote patency, we want to alleviate that obstruction so the patient can breathe better. That can happen in any swelling condition of the upper respiratory tract, primarily during laryngitis. Okay? I want to talk about laryngitis not because it's the sequential or chronological anatomical location from the upper airway down, but because the larynx is, in my opinion, one of the most important areas because it's the opening of the trachea. It's the opening of the airway. So when you develop laryngitis, the mucous membranes to the opening of the airway become inflamed. It can be caused by bacteria, it can be caused by viruses. What we're going to be noticing is a hoarseness in the voice. The issue with laryngitis is that in children, because their anatomical structure is a lot more compact, they run the risk of developing complete airway obstruction. And because of that, we have to be careful for stridor because it signifies airway obstruction, and we have to intervene accordingly. Laryngitis or any other bacterial infection can be cured with or alleviated with antimicrobial medication or antibiotics. Okay. One thing that's of concern outside of laryngitis is what we call tonsillitis. Okay. And tonsillitis is important because the tonsils are part of your lymphatic system, and they're at the opening of the oropharynx, and they're there to protect you from bacterial infection. The problem is sometimes those tonsils become inflamed significantly enough that they may necessitate a therapeutic tonsillectomy, meaning the removal of the tonsils when the advantages of having them on is no longer sufficient enough, because having them on is causing numerous tonsillitis infections, and it's causing more issues than actual relief of symptoms. So what I want you guys to know about tonsillitis, outside from the pain, which is also going to be manifested with laryngitis, is that in tonsillitis we can need something called a tonsillectomy. Okay? And in a tonsillectomy, you have the removal of the tonsils. A couple things you guys have to keep in mind after a tonsillectomy. Your role as a nurse primarily involves education and pre and post-op teaching and observation for complications. So before the tonsillectomy, you have to educate your patient that you will be observing for potential bleeding, which involves deglutition, swallowing. If you have a patient that continuously swallows, you have to observe for potential bleeding, and you have to assess. The assessment parameters involve inspection of the oral cavity, but also see their stool if there's melanoma. Also, systemic effects of bleeding, such as assessment for vital signs, hypotension, tachycardia, tachypnea, tachypnea, changes in level of consciousness. All those are indications that the patient's bleeding, and that's something that you have to consistently look out for. A post-tonsillectomy patient, we're going to be, aside from bleeding, okay, we're going to be educating the patient. And our education is primarily based off of the idea that the patient will be educated not to clear out the throat forcefully, because it may dehisce the stitches that were left when you perform the tonsillectomy. Any excessive coughing or clearing out of the throat may dehisce those sutures, which may exacerbate bleeding. You have to educate the patient about their oral intake. Once the patient has their gag reflex that has returned and they're able to tolerate PO intake, well, at that point you want to provide cold beverages. Keep in mind that they're going to be non-dairy, because you don't want the dairy products to produce more mucus, which is going to cause the patient to clear the throat more. And those are going to be contraindicated for your patient who's post-tonsillectomy. You have to keep in mind that you educate the patient about not consuming elements that are red or purple in color, any color that may mimic bleeding, because how would you be able to distinguish whether the patient is actually bleeding or whether it's the sorbet that you took a little while ago, that you had a little while ago. You have to keep in mind that these patients will be also offered a frozen neck collar. This is a very simple gelatinous substance that you put in the fridge or the freezer, and you can wrap around the neck, and you will provide cold soothing, because cold temperatures provide vasoconstriction, which will limit the bleeding to the site. Those are all post-tonsillectomy elements that you're going to have to be consistent with in your education for the patient. Moving on, when somebody has laryngeal cancer, this is a different monster. When we have laryngeal cancer, you have to now consider the holy trinity of cancer treatments: chemotherapy, radiation, and surgery. Let's talk about surgical procedures. So a laryngectomy. When we have a laryngectomy, which I'll write down right here, a laryngectomy will consist of your being able to educate the patient as to what to expect, how to prepare for the physical modifications after the laryngectomy, and your job as a nurse to communicate with the patient. So first of all, the larynx is the voice box. Once you have a laryngectomy, the patient will no longer be able to communicate with you. So you must find a means of communication. So we're talking about a communication board. Whether it's a poster with different images on it that the patient can point out to meet their needs, whether it's defecation, whether it's urination, whether it's they're hungry, whatever the case is, you need a communication board. You also need to educate your patient on how to adapt to their newfound stoma, okay? The stoma. Keep in mind that the larynx is the communication between the upper respiratory tract and the lower respiratory tract. It's the midpoint that opens to the trachea. So generally speaking, our nose with the mucous membranes inside and the little hairs that we have, they filter out particles. Now we won't have that ability anymore because the patient's going to be breathing from right here. So what we end up doing is we provide a light scarf. A light scarf is able to wrap around the neck, not tight, but just wrap around the neck, and it will be able to filter out any particles that may otherwise enter the airway and cause coughing reflex to be elicited. You want to keep in mind that you educate the patient on not getting any water inside the stoma. So you educate the patient to take baths in lieu of showers. When you're taking a shower, even if you get stuck in there in the shower with that hot water for like several minutes, the water may go from the back towards the anterior stoma and the patient may aspirate. The patient may aspirate. So because of that, we have them take baths instead because we can control how deep you go inside the bathtub and how much water goes in your body when you're taking a bath versus taking a shower. So because of that, post-laryngectomy, the patient is going to be able to take baths versus showers. And these are elements that you have to educate your patient about. Keep in mind that the only part that we are disrupting when it comes to the laryngectomy is the communication between the upper airway when it comes to the movement of air to the lower airway, because now all that air is coming from the stoma in this location right here, okay? So the patient will no longer be having any, not no longer, but the patient won't have any issues with eating because the patient can swallow just fine because the airway is anterior to the esophagus. So every time the patient swallows, deglutition is going to be enabled and the patient will be able to swallow just fine without potentiating aspiration, okay? So those are the components that you have to keep in mind for laryngectomy. I want to discuss bacterial infections of the upper respiratory tract. It doesn't really matter where it's at, whether even impetigo contagiosa, which is an integumentary disorder, is caused by staph strep, right? So any upper respiratory condition, I want you guys to keep this in mind. Any upper respiratory infection that's caused by Streptococcus aureus, right? Streptococcus aureus is part of your natural flora, the good bacteria that protects you. But in some patients, the strep may become prolific and it may become infectious to your own body. And this becomes a problem, especially in the younger populations, the pediatric clients, because they don't always take the full course of antibiotics that are designated for strep infections. So we're working under not an assumption, but we're working under an idea, a rule. And the rule is when somebody has an upper respiratory infection, statistically speaking, they have the likelihood of not taking the full course of antibiotics. That means that the strep does not die off, and it usually ends up destroying two structures later on in life. I'm talking about like a couple weeks later. It goes to your kidneys and you develop glomerulonephritis, or you develop rheumatic heart disease, which can damage the valves and the endocardium. So because of that, you have to ensure that the child takes the full course of antibiotics whenever they have an upper respiratory infection, whether it's tonsillitis, whether it's pharyngitis, and they have to take the full course of antibiotics to make sure that they get rid of the strep completely, because it could later on develop into glomerulonephritis and rheumatic heart disease. When it comes to the upper respiratory infections, folks, keep in mind that if it's a viral issue, you allow it to run its course, meaning that it'll either kill you or it'll run its course. And usually it runs its course, let's say it's like COVID-19, right? But you have to ensure that you provide the adequate interventions. If the patient has excessive mucus, you provide mucolytics. Mucolytics are medications that liquefy secretions and help you expectorate. Keep in mind that anytime you take any type of mucolytic drugs, that you have to increase the patient's fluid intake, because what the body does to liquefy those tenacious, copious secretions is it pulls water from the circulatory system to liquefy those secretions, to therefore expectorate them. So you must increase the fluid intake because it may cause dehydration. And anytime that the patient has any coughing issues, you can develop pharyngeal tears inside the throat that can cause bleeding and potential complications. So you give antitussives. The general idea of antitussives is that it suppresses the cough reflex from the CNS. So keep in mind that when giving antitussives, the central nervous system may be suppressed and the patient may develop drowsiness. So you have to ensure that they're not partaking in any particular events that require for them to stay alert. And when someone develops any type of issues with fever or any other general conditions that are elicited by infections, you give antipyretics or cooling measures accordingly. One thing that I want to emphasize before I conclude this upper respiratory tract infection issue is that if the patient has any condition, when the question asks you, which of the following initial responses or initial interventions, the rule is that you always start with the least invasive, least restrictive, non-pharmacological interventions first. After you've exhausted those attempts, then you move on to the more invasive, more aggressive, more pharmacological interventions, and so on and so forth.